we can move on with the next presentation uh, with the topic imaging, diagnosis, and follow-up of advanced and oligo-metastatic prostate cancer, PSMA PET-CT. We have presentator Dr. Kalnina, Riga Stradins University. So please, we wait your
Hello.
presentation.
Hello, colleagues. I'm happy to be again here. It is an honor to be invited this year and also last year. And today I speak about PSMA PET and show you how I see as a PET imager the diagnosis of prostate cancer. And if we look at the nuclear medicine point of view, actually at the PET-CT point of view, then we can explore prostate cancer from different point of views, either metabolic, either receptural. So as we know that metabolic agents, the mostly used fluor 18 FDG represents a glycose metabolism, and choline represents metabolics of phospholipids and etc. But these are metabolic agents that were used earlier for prostate cancer diagnosis, but now the new way of look at it, it's receptoral. Receptors and no PSMA ligands is now mostly used actually when available. And the first was with labeled with gallium, and now we work already with 18 fluorine PSMA ligands. And till now, gallium PSMA is more widely used, but there is a quite fast switch to fluorine PSMA, and I will explain why. If we look at the PSMA, what is this? The name is so nice and so promising, the prostate-specific membrane antigen. But actually it has different names. For example, in biochemistry, it's glutamate carboxypeptidase 2. In neurology, it's NAALA-dase, a long name. And in gastroenterology, it has even other name, folate hydrolase. But for us, it's just PSMA. And increased expression in prostate cancer, it's actually 100 or even 1,000 times more expressed in prostate cancers than in other processes, in other cancers, but still they may be expressed in other cancers or even in benign conditions, because PSMA actually represents the neovasculature. And this we need to keep in mind. And also for prostate cancer, not all prostate cancers represent the PSMA expression. Some papers show that even 8% of the prostate cancers can be PSMA negative. And that is also important to keep in mind. And again, if we talk about gallium-labeled PSMA ligands and fluorine 18 labeled PSMA ligands, there is a small difference. Most of them are highly expressed in salivary glands, in lacrimal glands, and it excretes through urine and through liver. But for gallium, urine is the first way of metabolism, and that's why it goes through urine and through urinary bladder. That may be difficult for local cancers or for local recurrences to be detected. That is a reason why we like to move forward to use more fluor 18 labeled PSMA ligands, as it metabolizes more through liver, and the urine is quite rarely active, and it does not express PSMA as much, and we can more clearly see the prostate bed, the prostate itself. And when to use PET-CT in the natural history of prostate cancer, as you can see in very different points. at the beginning a diagnosis to target biopsy or to target focal therapy, also for staging, mostly for high-risk patients for NM staging, and for restaging for biochemical prostate cancer recurrence in patients eligible for salvage therapy. And also we can use PET-CT for advanced disease, for non-metastatic and castration-resistant prostate cancer, and also for advanced disease just to monitor therapy and to address patients also for therapy with radium or radioligand therapy and assess response to those. This is one nice example. It's from the literature. It was published a few years ago, and it clearly shows that actually expression of PSMA in prostate cancer cells might be different during the natural history of the disease. And this is the same patient. At the beginning, the prostate cancer itself expressed PSMA, but later it was more neuroendocrine differentiation, and PSMA was not expressed so good, but DOT and NOC, that is somatostatin receptor expression, was more better seen, and even later when the cancer became de-differentiated, FDG, glucose metabolism, was higher than other ligands. And actually it changes management, of course, and this is a very interesting case to see that actually we don't have one nuclear medicine technique that we can use in all situations, and in the future we need to use other ligands in a specific situation for the patient. There was also one paper showing that how prostate tumorigenesis and aggression actually impacts how we can see and which is the ideal tracer during the natural history of the disease, and we don't have an answer yet. We think that PSMA may be more for earlier stages and for later, for tumor growth, for castration-resistant prostate cancer, we need to switch to FDG or to somatostatin receptor peptide PET-CTs. This is all different PET-CT ligands, and yes, we need to use the right probe for the right patient at the right time during the natural history of the disease, because the clinical needs differ. And last year, it was a big step for nuclear medicine in prostate cancer diagnosis, because at the National Comprehensive Cancer Network guidelines, it was recognized that it is stated that the panel does not feel that conventional imaging is a necessary prerequisite to PSMA PET, and that PSMA PET or PSMA PET MR can serve as an equally effective, if not more effective, frontline imaging tool for these patients. And also in European Association of Urology guidelines, it's stated that PSMA PET is more appropriate in end staging as compared to MR, abdominal contrast enhanced CT, or choline PET. And however, we need to keep in mind that micrometastases less than 5 millimeters are still missed. This is a resolution of PET-CTs. And the most clinically important indications for PSMA PET is staging for intermediate high or very high risk prostate cancer patients, persisting or recurrent PSA after radical prostatectomy or radiotherapy, and progressing castration-resistant prostate cancer. And we did also our local investigation. We took our patients, and this is our latest publication from our group from Riga Stradins University. And what we saw that compared the combination of MRI and bone scintigraphy together, fluorine 18 PSMA PET provided a superior diagnostic accuracy except for the local recurrence, where it was at least fully equivalent to multiparametric MRI. And these are really very promising results, and these papers are becoming more and more. And as you see, the guidelines already recognize that. There are some cases we saw. This is one with gallium PSMA. This is quite usual case when we see a small node, less than 1 centimeter, and 0.8, and this is a recurrence of prostate cancer in small lymph node in pelvis. This is another case already with fluorine 18 PSMA. As you can see, the urinary bladder is not seen. You can see just the local recurrence of prostate cancer with PSA very low, 0.5 for 68-year-old patient which had prostate cancer from 2013, Gleason 4+4, and after radical prostatectomy and biochemical recurrence and radiotherapy previously in 2014, and these images are from 2019. There is another case. Patient had he was 57 years old, 4 years after radical prostatectomy, and the PSA level at the time of the study was 0.38, and fluorine PSMA accumulation was seen in the prostate bed. And you can see also in MRI sequences that the lesion was seen also there with early contrast enhancement action. And the images really are showing the same as PET. Another example, when fluorine PSMA and MRI was done for 67 years old patient after radical prostatectomy 1 year ago, and the PSA level was 0.48, and the fluorine PSMA accumulation was seen on the left side of prostate bed. But the corresponding MRI didn't find anything, but it was proven it was a local recurrence. So sometimes we can see even these cases. And here, one patient also with fluorine PSMA and MRI, 66 years old patient after radical prostatectomy 1 year ago, and PSA level at the time of the study was 1.18, and fluorine PSMA accumulation was seen on the right side of lymph node in the front of the right iliac artery, confirming metastasis. But in MRI, it was seen as non-specific because of very small size, and you can see that sometimes it's very difficult for these sub-centimeter nodes in MR to conclude. And this time it even was concluded that it's not specific, but PSMA showed a different situation. But also, despite the beautiful name, prostate specific, as I already mentioned, we can see a lot of pitfalls in PSMA PET. We can see other tumors. We can see lymphomas and myelomas and thyroid cancer and rectal cancer and lung cancer. And so it's actually not so specific as it states. And there are some interesting cases from our center. We found prostate cancer recurrence in lymph node, but we also found a thyroid cancer that was treated after our exam. And another patient, we didn't find prostate cancer recurrence, but we found hepatocellular carcinoma that patient didn't know previously. And also in the last years, there are some guidelines how to report the PSMA PETs, and it's actually important for us to report the same as the other world. And at the beginning, they introduced the PSMA RADS system, but now it is more recommended to use MIRADS. MIRADS standing for molecular imaging RADS, and there is 5-point scale. benign, probably benign, equivocal finding, standing for MIRAT3 or MIRAT4, probably prostate cancer, and MIRAT5, definitive evidence of prostate cancer. And this is more useful to everybody to understand what do we mean. And if we look at the publications, actually already from 2016, how PSMA PET modified treatment approach in patients, and in this study there was 131 patients, and even in 76% of them the treatment was modified. And the main categories of PSMA impact was to avoid planned ADT in 64% patients, to avoid salvage radiotherapy in 22%, and implement ADT in 13%. And in all 34 oligo-metastatic patients, PSMA had an impact on HIFU, on salvage radiotherapy, and salvage lymphadenectomy. And this study also very nicely shows that with low PSA levels, lower than 0.5, also the clinical impact was very important after PSMA, and PSMA was positive in prostate bed, in pelvic nodes, in retroperitoneal nodes, in bone, and the pre-PSMA intent to treat has been changed in 90% of the 41 positive PSMA patients and 31% of the whole population. The clinical impact is really important. And next, actually, we started this with some of the patients, but still we need to go further for the theranostic principle for metastatic castration-resistant prostate cancer patients. And the principle is that we target the ligand for imaging first with PSMA, and later, when it's positive and it's metastatic, then we can use lutetium PSMA to treat those patients. And we can see there are some examples from Germany that we can see the baseline PSMA PET, and after 2 and 4 cycles, how changes really these metastatic spread and how the PSA drops. And actually, this is the direction we should go. And the largest randomized phase 3 trial compared lutetium PSMA to standard of care alone in 831 patients with advanced metastatic castration-resistant prostate cancer. The vision demonstrated that lutetium PSMA significantly improves overall survival and progression-free survival in patients with PSMA-positive cases. And this is from this year, one latest publication that shows that PSMA PET actually is a predictive biomarker for response to lutetium therapy that is really important to choose right patients for the therapy. And to finish my talk, actually, I want to just show that we are very, very dependent of radionuclides, and we also had some shortage in production of PSMA, and last year and this year we hope that in a few months we will restart it again, and to use actually the PSMA for patients, as it's still not registered in European Union, and still we have to produce it actually to use it. We cannot take the nuclide from outside. And there is a new activity, the project from the European Union, Horizon project, the PRISMAP, that is building a European network for medical radionuclides. And actually it has a great future because now it's difficult to get the nuclide, but in the near future we will have a network and we can get whatever we want. The other question, of course, is reimbursement and the costs, but it is a right direction for innovative diagnosis and innovative treatment. Okay, thank you. And maybe some questions.
Thank you very much for the presentation. As I see, we have no question from the virtual audience. So thank you very much for your experience, for your presentation.
Thank you.